Hello, everyone. I'd like to welcome you to today's ECHO session on navigating palliative care at home, insights from a bedside nurse. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabeg people. I acknowledge the historical oppression of lands, cultures, and the original people in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. Briefly, the Palliative Care ECHO Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. We encourage you to stay connected with us. Check out all of our sessions and what we're up to at echopalliative.com. And the Palliative Care ECHO Project is supported by a financial contribution from Health Canada. Therefore, the views expressed here are not necessarily representative of the views of Health Canada. Many of you might know Pallium for our LEAP courses. Predominantly, our LEAP core is one of our most popular programs. It is an interprofessional course that focuses on the essential competencies to provide a palliative care approach, taught by local experts who are experienced palliative care clinicians and educators, can be delivered online or in person. And to learn more about the course and topics covered, you may visit the Pallium website to check it out. My name is Diana Vins. I'm the Palliative Care ECHO Project Manager here at Pallium Canada. I will now pass it along briefly to our presenters to allow them to present themselves. Want to start with Paula?
Hi there, I'm Paula from Montreal. I work at NOVA. It's a nonprofit organization in home care.
Hi, I'm Jill. I'm a nurse clinician at Mount Sinai Hospital and Home Care in Montreal. So we're both specialized in home care palliative for many years now.
Fantastic. Welcome to you both. We're very excited to have you. We also do have my colleague Aliyah Mamdeem working hard with me in the background to make sure the session is running smoothly. I will now cover the conflict of interests. So Pallium Canada is a non-for-profit organization. We are partially funded through a contribution by Health Canada. We do also generate our funds to support operations and research and development from course registration fees and along with the sale of our pocketbook. I myself, along with the presenters, do not have anything disclosed, as you can see on the slide in front of you. And a few welcome and reminders. So for comments, please use the chat function. Along with the introductions, I do see many of you have introduced yourselves, so we're very excited. You come from various parts of Canada. That's wonderful. For questions, I urge you to please use the Q&A function, and the questions will be addressed at the end of the session. So for any comments, discussion, chat, and for questions, please refer to the Q&A. The session is being recorded, and the recording, along with the slide deck, will be emailed to everyone registered within the next week or so following the session. And please remember not to disclose any personal health information during the session. I will now pass it along to our presenters.
So we're just going to be presenting today, Navigating Palliative Care at Home, insights from a home care nurse.
And we're going to go through and walk through a little bit of what we do on a daily basis. So we just wanted to know if you guys ever heard this in the past when you guys go and visit a patient. You know, patient may be saying, I'm not dying. Why do I need palliative at home? And then other comments that my colleague will be presenting as well.
You can pop up the slides. So these are some of the challenges that we go through from day to day. Clients saying that I don't want to die at home. Some want to stay home. Some want to go to hospice. Some are asking us various different questions. I'm not ready for this. I'm not really dying. My doctor told me I'm not dying. So on our first visit with the clients, this is what we go through, and we're just wondering if anybody out there also goes through these types of challenges.
And then in our next slide, we're also going to talk about, what do we need to know in terms of providing home care. On the next slide.
Next slide. On our initial visit, we try to get together as a team and we do the visit together. And this is what we go through with the client: what to look for on your initial visit, understanding your patient's wishes, symptom management, support and planning, and resources and tools. So this might not necessarily be on your first visit, but the first visit is sort of to gauge at what we need to follow in the next visit. So next slide, please. So this is one of my strengths as a home care nurse, looking at the environment of the patient, seeing what the house looks like, what the client, how is the client, is he surrounded, is there other people involved, is he living alone, what's his religious beliefs, if he's a smoker, if he has animals in the house, if there's any hazards in the house, carpeting, stairs. It's really important to look at all of these on your initial visit. Even though you're doing the process of explaining who you are and what the team does, I think the environment tells a lot about the person.
And what you want to know is, who really involved, because in home care, you depend a lot on the family and the caregivers, and it could be neighbors, it could be friends and family. So you really want to know as much as possible who's involved in the care. We tend to do a lot of looking around. It gives a nice history of who your patient is. It walks into their environment. It can be very disorienting if it's the first time that you do home care, because you're not in your environment, you're not in the secure environment of a hospital. So
you're in their environment.
Exactly.
So, as you see the picture that we posted there, that looks like a great house to visit. But this is not always so. We've seen a lot in different houses, and this gives you a great idea on what to go next and where to go next.
And for animals, we try to keep them as, they are part of a family for most patients. Just be aware that pets can sometimes be a little protective of their owners. So just kind of try to gauge, would it be possible to put the dog aside if you're doing a physical exam or any type of procedure, because they can tend to be a little bit overprotective. So if we go into the next slide, and it's really to get to know as well on the first few visits is, explore what they know about their illness. Ask them how much information did they want to receive. Explore what's important for them.
They might not want to talk at all on the first visit. They might just say, okay, thank you very much. Nice to meet you. Can you come back another time? There's nothing wrong with me. So the first visit is really the most important visit. It's how you plan your next visit, how you plan your plans of goals with the client. And then, there was various communication tools on how to gauge things with clients. We'll go to the next slide.
So we usually use tools such as the serious illness conversation. It's really to try to set up the conversation, ask permission. Sometimes I'll use the environment of the house to start the conversation. Looking around, looking at family pictures that's on the wall. It helps with the setup of the conversation and to start the conversation on, getting to know the patient, but also talking about more difficult things, asking permission, asking if the family members would want to be there, or if the patient will allow.
Part of the conversation.
Yeah.
Sometimes the family might say no. The client might say, no, I don't want my family to be there. I'd like to talk to you alone, and then the family can be slowly introduced. Or sometimes there's lots of family members and they're taking over the conversation, but we really need to refocus back on the client and ask the client what the client wants.
Yeah, and a lot of times, don't be afraid. There's gonna be television, so you'll have to tell them, can we turn off the TV? The phones are gonna be ringing off the hook if there's multiple friends that will be calling. So there's a lot of distraction in the house that may interfere with the conversation. And I think the focus is try to get as much as you can in this tool, but not necessarily to go through all of it. And you may not get to half of it in their first few visits. It takes a little bit of time and takes a little bit of working on.
Maybe the 6th visit, might be the 7th visit. You might talk about this on the first visit. It really, the client is in the driver's seat, and we just go by him and or her and see what they would like.
And then if we go to the next slide, I use the nurse's statement to have empathetic response where, I might see that they might be emotional, so I might be naming it with them. I might try to understand it and respect and supporting and exploring them. I'm not going to go into too much details about how we usually use these conversations. There's
but this is a great tool to use,
yeah.
Especially for newer palliative nurses too. It's a great tool to use.
So there's other videos, I think, or webinars that were done previously on Palliative ECHO about tools on communication with more in-depth explanation of all these tools. The I wish statement works wonderfully at home. I wish we could keep you at home, but what happens if things are not going as planned? So this is something that we open a discussion for in terms of planning at home, because anything could happen. But don't forget, the family and the patient are alone at home. They don't have the type of same support that they have in the hospital where they could turn around and call a nurse. There's a certain amount of challenge where there's time that could be elapsing in between the phone call that the patient calls us and us actually being able to get to them. So if we go into the next slide.
This is why we try to bring in as many intervenants on the initial visit. So we bring in the CLSC nurse, which is the community nurse. We bring in the Mount Sinai nurse, which is also a community nurse, and the Nova nurse. So we try to do the visit all together on the initial so we can plan out their goals of care.
So don't forget, guys, we are from Montreal, so you guys will have to excuse us if we use a little bit of French here and there. That's just a Montreal kind of thing that we do oftentimes. And then we tend to do, addressing the goals of care. What can we do to reframe, to expect, to map, to align, and to plan? Really, that is a work in progress in home care as we go along, because oftentimes when we do our first visit, the family and the patient will say, I absolutely want to stay at home and I want to die at home. And sometimes we'll be just looking at each other and say, how are we going to do this? How are we going to pull this through? There's a lot of challenge that we're expecting that maybe the family is not wanting to hear about it at this point. But it's always good to have the remap and addressing the goals of care, and to have a plan and to look back at the plan as we go along, as the patient is followed by us with time.
And establishing a trust in the team. It's really important that the client trusts the team, that we're open and honest with the client and the family, and we include everybody. And as Jill was saying, even the pet, we include as part of our initial visit. So it's really important.
So if we look at the next slide, this is a little bit of who can be involved in the care. And as you guys can see, it could be quite overwhelming. So you kind of want to tell the patient and the family to expect that in order for us to try to keep you at home, we really want a security blanket, a safety net with a big team that we could keep the patient at home, and we could really try our best and prolong the time where someone could stay at home. So, as you can see, the patient, but it's not just the patient, it's family, friends, pets, neighbors, and whoever is involved. Then you have the nurses, physicians, social workers, occupational therapists, and
personal support workers, nutritionists, a spiritual guide. Again, I'm from Nova, Montreal. So Nova is a nonprofit organization, and across Canada, it's known as the VON. And we also supply a lot of comfort, massage therapy, respite care for the family. So it's a multitude of different professionals that will get together to really maintain the client at home and give the support to the family and to the client.
Yeah, so it's really, I think it's important to acknowledge that it will be overwhelming, and we understand that it is overwhelming to have everyone there, and they might be confusing all of our names, and then that's fine. Who do we contact, and how do we contact you? And there's just so many people coming in, and it's really important to acknowledge that in home care,
and also support for us as well going in. So all these extra little people that are around us give us support as well, because yes, we're going through the challenges every day of seeing these palliative clients, and we do need a support group. So it's really nice that we have all of these other professionals that will be involved, and we can work together to give the best care for the client at home.
So if we go into the next slide, it's to get to know each other, and it's really important to acknowledge again is that it's overwhelming with the team, but to explain our role, to support each other in our role. Oftentimes, the nurses, the doctors, social workers, we're seen as more of the good people because we will be there and supporting them. The occupational therapist might take of a role a little bit more complex, where they're changing an environment where we feel like
the client was used to. The client had was walking on their own, and now they may need a walker, or they may need a bathroom that is adapted, or there's stairs that they can no longer go up. So the occupational therapist has a big part in the role of keeping the client at home, but that occupational therapist might not always be seen as a good person because they're adapting and changing the house environment.
And keep in mind that changes in their environment will probably project as changes in their own health and changes in their projection of trajectory of disease. So it is a big step, and I think it's really important to acknowledge that, and this is why we tend to work on a big team, and to have maybe joint visits done together. It's usually good. Sometimes we'll do a visit jointly with a social worker, so the social workers could focus more on the social part, and then we'll come in and go in with a little bit of the nursing and the medical perspective.
It's really a team effort to maintain them at home. So and a gentle approach. I mean, this is a gentle situation. It's hard on everybody. So going in and explaining everything, giving them our phone numbers, giving them emergency numbers that they can contact us after hours. Some patients like to give email addresses, so we're open to giving email addresses to our clients. Really having that close contact with them, so they feel that the house is a good, safe environment, and they don't need to go to the hospital right away.
Yeah, and sometimes, bringing it back to, again, we're giving you that support system, and we're trying our best to have you with a security blanket and the safety net that we could give you to try to keep you at home. And usually, again, I see it in chat. A lot of people are telling me, saying, the I wish, and the I wonder. It's a great gentle tool, and that's what we tend to say to the patients as well. Our goals and our wishes, and we wish that we could keep you at home as long as possible. And this is why you have all the tools, and this is just adding to your toolbox.
Yeah, and this is why the team is all introduced, because the more team members you have, the more players you have, the more you could be safe and protected at home, which prevents you again from going into the hospital or an emergency situation. So that's not to say that we never have a plan B. We always have a plan B. If it ever gets to a situation where the client can no longer stay at home, but we try our best 100% to try to keep them at home and offer whatever resources we can to keep them at home.
And if we go to the next slide, we could talk about, providing symptoms management. So on our first visit, we tend to review some of the symptoms. There's not one perfect way of doing review system, and looking at what what is bothering them. So I know Paula likes to lead the interview by doing a review system and asking questions directly. And it comes with certain advantage. I don't know if Paula, you want to talk about that?
So I'm more of a direct person. I like to follow through this. Well, I kind of gauge at the client first to see where they're at. And once I know where they're at, and if they want to speak, then I will go directly and say, how is your pain? How is your fatigue? How is your sleep? And I'll go through all the symptoms. But it's really a gauging thing. I think it's really, again, going back to the environment, going back to pictures in their house, going back to, you really have to have your eyes and ears and looking around before you jump on them too, and get them anxious and know where they're at. So back on our slide before, when we said know your client, know what they want, once you do this, then I like to be direct, whereas perhaps Jill has a different approach.
So I'm a little bit, I like to call myself a little bit more scattered. So I'll have more of an open discussion approach where I'll tell them, tell me how your day looks like, and they describe me your day, and in my head I'm going through the symptoms with them. Unfortunately, that type of approach might take much longer time. If you have a very chatty patient that loves to chat, you may be there for hours and hours. So just use that as you look back at your patients and you see if it's appropriate.
We have a nice connection, Jill and myself. We actually work quite well together when we do an interview with a client on the first assessment. We kind of tag team each other, kind of like what we're doing right now. And I think it gives the client a little bit of comfort to know that the nurses are close with each other, that they're able to finish each other's sentence, let's say.
So, I see in the Q&A what discipline meets with the clients for the first time. Oftentimes it is the nurses that will meet the client. And what we do is, as you can see, is we're so many disciplines coming in, and even so many organizations coming in. There is, this in Quebec, the CLSC, so the home care team, the nonprofit organization teams, that it is tiring to always interview the patient in different matters. So we tend to kind of do a lot of joint visit and to complement each other. So if one person forgets something, the other person will kind of jump in and help out and refocus on some of the question. And the referrals really come from a lot from the hospital, but also from the community team. So the way it works in Montreal is that there is the home care team, but there's a specialized palliative care team. So a lot of time is, the home care team will see their patient deteriorating, and then they might say, hey guys, I have a palliative. Would you guys need be able to come and consult or come in and follow them? Can we transfer them to you? So it's really.
And we also have like a team meeting that we meet, we present the case, we talk about the case, so we give each other support in the file too, presenting the case and talking about it and seeing if other people have different. And on this team meeting, there's doctors, there's occupational therapists, there's a whole bunch of different professionals that we can explain, and we can get their opinions and make up a plan for that client.
Yeah. So once we go through what are the symptoms, what's bothering you, if we go into the next slide, we have, we usually use the Edmonton System Assessment Tool, or known as the ESAS, which will kind of refocus, and it's a great tool to use with the patient and family. It engages the family to help us as well, to look through this and to look through, weekly, if we do a visit weekly, and what are the changes, and if there's no changes or improvement. So this is a great tool to use. And if we go back to the next slide.
This slide can help us plan our visits. So if the client is symptom-free, excuse me, then our visits might not be weekly. It could be every second week or every third week. But if we see that things are changing, then we may change our plan, and we might see the client a little bit more often. So this is a great tool to use.
So if we look at the other side, and some patients might like to write them down, so this is another great tool from virtual hospice. So a symptom diary, they might want to keep this as we go along, and we look at things that might be changing. So these are tools that you guys could use. So if we go to the next slide, we look at, what should we consider in terms of symptoms management. First thing first, it's the capacity to understand the information. Be creative. So as an example, I had a patient at one point, I think I've done numerous visits, and we all tried to explain what is the difference between a long-acting opioid versus a short-acting opioid, and it just wasn't the patient wasn't grasping it, the family wasn't grasping it. So we end up comparing it to, the energizing bunny that really works for a short period of time, and then it runs out of battery, and the little turtle, and that's going slowly, but that goes to the finish line, but they end up going very slowly. So we use a lot of creativity in home
there's
care.
A lot of creativity in home care.
So again, finances is very important to look at. What you kind of want to consider is, it's great in hospital, we have a lot of medication, but is it really covered in home care? Does the government cover it? Is it accessible? And even equipment. Some equipment, the patient may have to purchase it.
Is there somebody at home that is able to administer the medication? And if they're not able to administer the medication, can we teach them? Are they teachable? Will they cope with administering the medication? So these are all things that we need to look at to provide safe care at home. The environment as well. Is there clutter? Is the client living at home? He may not be able to stay home alone because at end of life there's a medication that he has to administer. Can we use other resources? Can we use other groups that can provide service at home? The finances, are the client able to afford services at home? Will they be able to pay somebody? So this is a lot of, is their family out of town? Is their family in town? The communication between the family.
And again, is there younger children? Because you may want to take into consideration, there's young children in the house, there's other people coming in the house. Are the opioids, if there's any opioids, to be careful with that. So if we go into the next slide, I think we're looking at also the belief of the patient. What do they understand about the medication, homeopathic medication, alternative treatment? I think we've heard of coffee enema, or a lot of time.
Yeah, and
different ones.
Even if they have certain beliefs, I mean, in a way, we have to respect their beliefs as well. We can, yes, we're medical professionals, but we also have to have that respect for them too. So it's a little bit complicated when they're talking about a coffee enema and we're like, I don't think there's coffee enemas, but if that's what their belief is, we have to respect that, and it causes also some stress on us as well to deal with these alternative medications.
So the other thing is what happened in terms of medication in the past. I think a lot of you guys, or if not most of you guys, probably ever heard the patient telling you first thing first, I'm allergic to morphine, or I'm allergic to certain opioids. I had a surgery 20, 30, 40 years ago, and I had a bad reaction. I had some hallucination, and I'm completely allergic to it.
Or is the morphine gonna, I've heard about morphine, and I know that they only give that to clients at the last minute of their life. And so if you give me morphine, does that mean I'm at my last stages of life? So this is where we have to plan and explain the medication to them, and explain, we bring in some charts sometimes, we explain, we go through everything with them, and they already have that negative view of medication.
So it's even more important to reassure them about the safety of medication, and really what are the side effects, and be very open about the side effects and the benefits of each medication, because do understand that they are sometimes alone when trying these medication. So you tell them, I understand you have fears. Maybe you should try it tonight, and then I'll call you tomorrow morning to make sure that everything goes well. So just plan ahead that you have all that.
Yeah.
Community pharmacy, unlike the hospitals, it's not obvious sometimes to get the medication. You have to consider the opening hours.
There's no stat medications. There's calling around different pharmacies to see whether or not we can get a certain medication in at the same day. The delivery time, what time will there be somebody to pick up the medication at home, to answer the door? These are a lot of our challenges too with the medications in the pharmacies that we go through.
And when you find a specialized pharmacy to prepare it, because all these subcutaneous medication or injectable medication has to be prepared under a sterile environment, and then you may want to think of other alternatives. So we've done lozenges, lollipop, popsicles, suppository, elixir, etc. I mean, the sky is the limit as long as it could be done. There's
somebody to give it to them.
Yeah.
So, and there's teaching also, the pumps. Does everybody know how to use the pump? So there's a lot of teaching involved too, because yes, you have the palliative team, but a lot of the emergency numbers or the weekend numbers, maybe somebody doesn't know how to use a certain pump. So there's a lot of teaching involved as well.
So if we go into the next slide, what are the challenges the patient needs to know, right? Patient and family. Again, the response of the symptoms management strategy, what works for the patient, what may not be effective. You have to kind of prepare them in advance. You may see some side effect, and when they're dealing with a side effect, it is very stressful on family because they do not have
the medical background. They may come from another country. They may not be able to speak our language. There's speaking to the family that could speak English, but the client doesn't know how to speak English. So that could be complex as well, because we first have to explain it to the family member, and then in their language, maybe she might explain it a little bit differently. So these are another challenge that we deal with.
And then
just emotions of the family, families that are angry with the planning, clients that are angry with the planning. In the hospital, when you're in the hospital, if you need a blood test, it could be done immediately. In home care, the blood test might not be done immediately. There's planning involved. There's requisitions.
So any other diagnosis testing to help with symptoms management, it may not be available. I mean, I I don't foresee myself carrying any x-ray anytime soon.
Mhm.
I don't know that there's any portable one, but ultrasounds can be done at home. Bladder scans can be done at home. So it's really to go back and explain to the family, we do have diagnosis testing. They're limited, but we go through the symptoms, we go and review things with you, and to reassure them that we will try our best. Again, it comes back to what are your goals of care, how much investigation do you want to have, and this is kind of a little bit what we're looking at. So if we go into the next slide.
So this is providing symptoms management at the end of life.
So you always kind of want to be prepared for the worst case scenario, any emergency. So we tend to have this emergency toolbox to have at home.
We try to get our physicians to prescribe it right away so that we have this medication at home, so that if there is calls in the emergency numbers, the medication is at home. We try to explain with families. We ask the CLSC which is our community care nursing, to bring the needles or any type of tools to help with these medications. We write down the medications. We go over and over and over, repeating with the client what the medications are used for. We provide them with the emergency number. We reinforce it on every visit. You can call that number, or you can call the nurse during the daytime.
And it's important to really tell them, to reassure them, look, I understand you're not a healthcare professional. There's no mistake. None of these medication will be a mistake. We're trying to provide comfort. And if we go into the next slide, you'll see a little bit what I give my patients. So I have this template set up most of the time to leave at the house. Emergencies number there, the medication. I always have my phone number and extension on top. And really, what are these medications for? We do color coordinated. I don't think you guys see it on the bottom, but the opioids is a different color. So I have different highlighters that I would highlight it, and I would highlight the bags of the medication or the labels of the medication with it. So
we make it user friendly, so that anybody can come in the family, and they can, if they call the emergency number, they can say, give the orange one, give the blue one. So at least we're all on the same page together.
So if we go to the next slide, we also, it's important to provide that support to the family. And I think we've been talking it through our slides. It's really naming what's important for a family, brainstorm it together, explain what are the plans, and the plan, and that plan could change. Today we're looking at that, and tomorrow we might change our mind. How frequent do we go and see our patients? That's what we kind of want to determine on the first visit. It could be every second week, and in between we'll do a phone call.
If things change, they can call us, and we can change our visits. So we go according to how the patient is each day. So you can go to the next slide.
Yeah.
So this is some caregiver support resources. Again, just to mention, the occupational therapist, we can always refer to them, a social worker, any community resources. We try to give them all this information. We leave a folder at the house with all the information in it, so that the client can look through it, the family can look through it on their own time, and they could, on our next visit, then we can plan if they want to include anybody in the visits.
And what we tend to also like to do is, you'll see on the bottom, the virtual hospice website. It has really great video on how to administer medication. Things as simple as, and things that we think about oftentimes is, changing a diaper. It may be easy for a healthcare professional to change a diaper, but I could tell you, I have numerous patients and family members that said, I have no idea.
Yeah.
I had to YouTube it to change how to change a diaper, or how to turn someone in bed. So these are things that you really want to anticipate, and you have the videos there as well for the family member, and you can give it to them, email it to them. And on the next slide, we've included for the healthcare providers. There's a directory on the Canadian Hospice.
Some tools for us to look at. So, which is great. They're
And
great
then
tools.
the BC symptoms management guideline, on there, there's a little slide where for patient teaching, and these are things that we could think about or even have refer a patient there. So there's different type of resources available for us. I know in French, if anyone is fluent in French, the Patty Science also has an application for the phone. So it's great that you could go on it on the phone and pull out some of the information. So on the next slide, we wanted to present a little case study.
So Mr. Smith, 46-year-old man, lives at home with his wife and 2 children, 12 years old and 16 years old. Live in a cluttered upper duplex, has 2 cats and a dog. Spouse overwhelmed, no other relatives in Canada. Diagnosed with glioblastoma in 2023. He is ETOH, habits, drinks 1 cup of whiskey per day, smokes a pack, occasionally of recreational drugs such as cocaine. Mr. Smith is complete denial about his situation and refusing nurses' recommendations. Mr. Smith believes that his cancer is reversible and that his treating team will find the right treatment. So we just wanted to ask you, how would you manage this? And this is very typical, these clients that we get in our territory. We've had many clients like this. So this is some of our challenges, and you guys could ask some questions or provide us a way that you would manage this case study. I'll leave it to you.
One of the things that we've done is trying to establish a relationship, which sometimes it takes a little bit of time, and then just go in little by little. You kind of want to think it's the house is cluttered. Now, one of the other things that we look at also in home care, and I don't think we mentioned it in the past, is how the home looks like. But if there's some unwelcome
pets,
so you kind of want to anticipate that too. So do I bring a big bag? Do I bring all my equipment in there?
Do I leave everything in the car on a freezing minus 20-degree weather, which we have done? Bed bugs, mice, we've seen cockroaches, we've seen quite a bit.
And not to discourage you guys from home care, honestly. Depending on some territory, you do have that. But what we've done is, slowly go in and create that relationship with the wife, with the patient, slowly, little
and
by
no
little.
judgment.
Yeah.
I mean, like, if he's a drinker, no judgment. We just go in and we're very gentle, and we talk it out with them and try to do our best.
And I think, in this case, what we've done is look at medicine. We had what we call a lockbox, a box, a tool, a literal toolbox where we locked it up so that family or even friends or even the children cannot have access to it, just to make it a lot
and
safer.
We have seen where family members have broken the box, or family members have brought in other medications that are not prescribed. So this is another challenge.
Yeah.
And it actually is kind of nice because we work together as a team and we really make the best environment for the client under their situation.
And again, the smoking in the house, it may not be pleasant, so it's okay to tell patient, I'm going to be here for a short period of time. Do you mind not having a cigarette? Do you mind opening the windows?
And they might say, no, I'm going to continue smoking. And you have to sit there with them smoking and you have to respect what they want because it's their territory.
So, so this is kind of a little bit what we're faced with in home care. I think when we have someone in the Q&A.
We do. We have 2 questions in the Q&A. So we have the first one from Crystal Yang asking, are this kind of PEP teamed in a different area in Ontario that patients can call to request? Is this kind of service both privately and publicly funded?
I know in Ontario they have a home care kind of team too. I'm not quite sure the name, but they do have an Ontario team that will do home care. I think it has to be referred to by the physician in the hospital to this team. And then if they need support workers, then that is paid by this company, this team that does the care, but it's aside from that. So they outsource it to agencies that will do private care at home.
Fantastic. We do have from Samantha McDonald. Are you able to ask what is your expectation?
I think we do that all the time.
Yeah.
I think, you know, part of an ending question for us, and I personally like to use that a lot, is, do you have any questions for me? Do you have any expectation? What do you think will happen? Or what do you, and it's in the planning on what, moving forward, how often do you want us to come and see you? And what do you expect to have at home? What do you expect that will happen in terms of staying home?
And you will have clients that will fire you and say, no, I don't want this nurse, and that's okay. Like we're okay with that. I mean, we'll ask them. We'll ask them like, what don't you like? What is the problem? And we explore it. And sometimes when we start to explore with them, they start to say, well, maybe I was a little bit too hard with you. Maybe you should stay. Maybe we do like you as a nurse. So it's like they're in the driver's seat again. I let them take control, and in a respectful way. I mean, if there's disrespect, then, we'll address that. But with palliative clients, most of the clients are very respectful. The family's very respectful. And when they do fire us, sometimes we come back. We work on them, and they tell us to come back. So that's part of our challenges as well.
Yeah. Thank you. Thank you so much. I do not see any further questions. We have included a follow-up survey. We always love to see what you guys think about the sessions. So we urge you to please fill out our survey. Once again, I'd like to take this opportunity to thank our presenters. Wonderful insights from both of you, Paula and Jill. Always appreciate having you with us. And thank you so much for attending the session to all participants.
Thank you. Thank you.